Welcome to a podcast brought to you by the American Academy of Orthopedic Manual Physical Therapists. Our academy is a national organization committed to excellence in orthopedic manual physical therapy practice, education, and research, and we're here to explore a wide range of topics with you through interviews with content experts.
Hello, I'm Tony Varela. I am excited to be talking with Dr. Chad Cook today. Chad is a physical therapist, clinical researcher, and profession advocate with a history of clinical care excellence and service. His passion includes refining and improving patients' examination process and validating the tools used in day-to-day clinical PT practice. Chad really doesn't need an introduction since he is a longtime contributor to AOMT. I'm honored to talk with him today. I've invited him for his second podcast to discuss his recent manuscript titled Manual Therapy and Exercise Effects on Inflammatory Cytokines, a Narrative Review, published in Frontiers in Rehabilitative Science. This conversation promises to be enlightening and complements recent discussions on precision medicine initiatives and the need for biomarkers. Chad, it's so nice to talk to you. You've been involved with AOMT for a long time, as I have, and I'm surprised that we haven't met, but I have been following your work. With that being said, this particular manuscript caught our attention because it seems to be on the fringes of what you normally work on. Can you tell us why you wrote this manuscript?
Yeah, sure. And first of all, Tony, thanks for having me on, and thanks for the work you do with AOMT. We really appreciate it. I think we have a mutual appreciation of AOMT. It's a wonderful organization. The reason we targeted this paper, and if you look at the group, it's an interesting group. It's more basic science researchers, is that we did submit a large NIH R01, and we were really looking for preliminary data around not only exercise, but manual therapy effects on cytokines, because we really couldn't find much summary literature that discussed it. And if you go to any Con Ed course or listen to podcasts or whatever, there's kind of a suggestion that manual therapy has an influence on inflammatory components and neuroimmune components in the body. So we were keen to actually dig in and see what the literature actually said.
Well, and as we move forward, we'll explore what that literature said. But can you first lay down some foundational definitions? Like, what is a cytokine and what is a treatment mechanism?
Yeah, probably a good idea. A cytokine is a protein released by different tissues within the body. They're chemical messengers, typically for the immune system, and they're reactive, especially when there's been infection or inflammation or trauma, and they help regulate the immune and the inflammatory systems. As physical therapists, we probably have considered cytokines when dealing with patients who have maybe elevated pain perception. We know that cytokines can sensitize nociceptors. We know that cytokines could potentially be involved in individuals who have autoimmune problems and theoretically involved in individuals who have nociplastic pain too. And it's a way of understanding components of the disease mechanisms in a person's condition. And the second question, what is a treatment mechanism? I usually describe it by saying, if you try to describe to your patient how a treatment works, treatment mechanism it's essentially how the intervention interacts with the body or the mind that actually produces the overall clinical effect that we see with our patients. So it's kind of like how the sausage is made, so to speak, what that intervention actually does to the body and to the mind physiologically that leads to those clinical outcomes that we see.
So if I'm putting those two thoughts together, the suggestion is that exercise manual therapy is potentially working as an intervention through the influence on the cytokines as the treatment mechanism.
Yes, and that would be one of the treatment mechanisms. The challenge is that scientists often think with blinders and actually look at things individually. The challenge with studying treatment mechanisms is that they interact a lot and that there are probably 100 different mechanisms that occur with your treatment that are responsible for those clinical outcomes. It's probably not just one thing, but certainly altering cytokines can be a reason why we see the clinical outcomes that we do.
So, and that's altering cytokines in a positive and or negative way, correct?
Yeah, that's really good insight on your part, because there are some interventions we do that can actually stimulate pro-inflammatory cytokines in patients will report that they're actually worse. We see it with exercise. We can most likely see it with really aggressive manual therapy, even though that hasn't really been studied to my knowledge. But indeed, it can influence it in either way. And there are two types of cytokines. There's pro-inflammatory, those tend to increase inflammatory biomarkers, and then anti-inflammatory, which tend to regulate the inflammatory response. And then there are some cytokines that actually function as both. So really, it's actually quite complicated.
Well, and speaking of that complication, it seems as a general statement that you are attempting to categorize the muscular system as a separate organ or endocrine system. The idea being that exercise and manual therapy is addressing the myofascial systems.
I don't think you can define the disease mechanisms as clearly in the musculoskeletal system as you can in something like cancer or something like an autoimmune disease or something that is more easy to identify. These are the distinct disease mechanisms. There's very little research on disease mechanisms on a lot of the very common musculoskeletal disorders. If we take our biggest population, nonspecific low back pain, we really don't know the causal disease mechanisms that are related to that. I have seen some work where people have tried to categorize subtypes of musculoskeletal conditions like myofascial related pain, where they tend to say the disease mechanisms are primarily at the myofascial junction, etc. But in reality, most musculoskeletal related problems involve multiple systems. So it's really hard to suggest that it's a single system.
To kind of reiterate what you said, make sure that I understand it, that the listeners understand it, is that the musculoskeletal system is playing a pivotal role with the other systems and organs.
Yes, it interacts with other systems. And those interactions, which are often very difficult to measure, are different from person to person and from condition to condition, are one of the reasons we see such variability in the patient's presentation and also a tremendous variability in their response to even efficacious outcomes.
Knowing that cytokines have their role in MSK or musculoskeletal related pain, how can the practicing clinician better evaluate and treat these low grade inflammations and incorporate some of these thoughts that we're going to share about exercise and manual therapy and the influence it has on the cytokines?
There are a lot of different conditions that will have a low-grade inflammation. We do work with those a lot. And indeed, autoimmune disorders, certain types of pain mechanisms like nociplastic pain, etc. It's worth having an understanding of what sort of things actually do at a systems level influence inflammatory cytokines. Certainly, you mentioned exercise already. We know that certain types of exercise, and it's my hope we get into what do we mean by types of exercise and dosage, et cetera, because that's worth talking about. There's exercise. Diet has been shown to influence cytokines. A big area that has really increased recently in study is sleep and also stress management. Stress management is a huge element, and we do our best, I think, as clinicians to alter that. Sometimes they have to go outside our profession. And there's certain behavioral related things too, such as smoking, excessive alcohol use, sadly, is another one. So all of those things kind of interact together, which all influence low-grade inflammation. Manual therapy, more on the fence with respect to that. We've got some findings in the paper that are interesting, but we probably know less about it there's more we don't know about it than what we know about it.
Well said. The paper clearly identified there's an influence from therapeutic exercise or just exercise as compared to the manual therapies. Can you expand on that a little bit?
Yeah, there's a lot of literature on exercise. And if your listeners will read the paper, they'll see that these papers were so dissimilar in how they evaluated this. There were preclinical studies, there were clinical studies, healthy subjects, there were individuals with different pathologies. We included anything that was even beyond the musculoskeletal problem because we were really looking for the direction of the input and exposure to exercise or manual therapy. What did it do? Did it increase it or did it decrease it? And all those variations can lead to different results. But as a whole, exercise, aerobic, and resistance was fairly consistent on its influence on the inflammatory system, and then just heaps of exercise on it too. So I think on that part, we have a strong understanding of the regulatory effects of exercise. That's really key. It is something we can thoroughly endorse.
I would like to circle back to your comment about expanding on exercise and physical activity. I often find that patients tell me they participate in a lot of physical activity as opposed to different forms of exercise. So, as an example, they feed their chickens, they clean their house, they do some gardening, tend to their kids, but they do not have a formal exercise or organized exercise plan. Do you think those physical activities play a role with the cytokines like exercise? And if so, how can the practicing physical therapist end up incorporating that so that it helps the anti inflammatory cytokines?
Oh, heck yes. That's a great question. For starters, I've been a physical therapist for 34 years, and I've heard the same thing from patients. They'll say, hey, I'm busy at work. That's how I get my exercise or whatever. But we know for regulatory components, to moderate the pro and anti inflammatory cytokines, you need two things. There needs to be control of intensity, and there needs to be structure. So the intensity piece is the dosage, the strength of the dosage, and the structure piece is a time-related component. So it needs to be regular, it needs to be consistent, and it needs to have a time-oriented element to it. And the challenge with physical activity, which has, as you know, has a very wide definition, is physical activity doesn't necessarily have an intensity and structure component. The idea behind that intensity and structure is it builds accommodation in the body, and then you start to see changes in cytokines. So that's how formal exercise programs, more regulated exercise programs, are always going to outshine physical activity. We still promote the physical activity because it has external benefits, right, related to weight loss and mental health and a number of other things. Those are all positive. But if you're looking to change and to do physiologic regulation, it really truly is about intensity and structure. And that part needs to be regulated.
Very clear and actionable. And I completely agree. Intensity matters. At the same time, I would assert that most physical therapists underdose their patients with the therapeutic exercise. So it has to be very individualistic. And at the same time, it has to push them to a certain threshold and have to have a certain duration. So, how would you describe that intensity for the practicing physical therapist?
You're spot on. The exercise intensity matters dramatically. In the few studies that very well defined what the exercise program was, there were notable changes in cytokines with the intensity of exercise. So if they underdosed and let's say did minimal intensity aerobics or minimal intensity, I'll throw some boundaries on that in a second, or minimal intensity resistance, you often didn't see much change in cytokines. If there were maximal doses where they were really, really intense on the aerobics or very intense on the resistance exercise programs, it actually countered the preferred direction of cytokine change. So you saw an increase in pro-inflammatory cytokines and a decrease in anti-inflammatory cytokines. In those studies that actually did a more structured, in other words, time-regulated exercise program that was more moderate, you saw the cytokine change in the direction that you actually wanted. You saw a reduction of pro-inflammatory, you saw an increase in anti-inflammatory. And typically when they talked about moderate, they suggested heart rates of 50 to 70% of a person's maximum heart rate. And then they gave markers around a one repetition maximum. So they talked about exercising at 60 to 80% of a one repetition maximum as being in the moderate phase. And your original comment, I think, really resonated with me that we underdose our patients. And I would argue that that is absolutely correct, that we're probably not dosing at a level that we see, these inflammatory and neuroimmune changes, that the changes we're seeing might be from some other system, some other mechanism. And if we really want to make changes there, we need to educate our patients appropriately and get them on a regular, structured program that falls within those intensities.
Those are some pretty good boundaries. Chad, let me just take a side note here. What I've noticed is I can dose a patient and predict their level of soreness almost to the hour. So I'll tell the patient you're going to be sore for about 8 hours. As it settles down, you'll start to feel a little bit better and you'll even move better and have less pain. And in your knowledge base and with your patient care, would you say that is part of the dosage? Is the way that they're going to respond over the course of, say, 24 hours?
So I'll answer it in a way that's, I think, will be independent of the actual research on cytokines, because most of that research was either on animals or on human subjects that were asymptomatic. So there wasn't that qualifier of, you're really going to be sore because of the condition that you have. But with respect to managing a patient, I think that's one of the skills that good physical therapists have. I always say it like this. I said, a lawyer will only ask a question that they know the answer to already in a courtroom. And we have to function in the same way. We can't spitball exercise programs and hope for the best. We have to actually use a priori knowledge and our understanding of a person's response and the pattern recognition that we see from seeing so many patients and our understanding of biology. Yeah, absolutely. That piece is a critical component. I think that piece is independent of what we found in our paper, primarily because the designs didn't take that into account.
Thank you for that clarification. And part of my intention is to figure out how this paper becomes actionable for the practicing therapist. And then, along those lines, how would you describe the increase in the pro-inflammatory cytokines with acute exercise and their temporary or lasting effect? Which is to say, the patient who is coming to you has been sedentary, guarded, overprotective, hasn't done a lot of exercise, may even be fearful of that exercise, but they agree to it and they follow your lead. And could there be an expectation that the exercise increases the pro-inflammatory cytokines and processes?
Indeed, it can. And in fact, quite a few studies did find that in early intense exercise, which they termed as acute exercise, that we often saw increases in pro-inflammatory cytokines, which is not necessarily what you want, because we think of cytokines, they're just responsive signals, right? They are signaled to respond a certain way. If a person is unhealthy, if a person is sedentary, if a person has a disease mechanism where there's an underlying level of inflammation already, it's likely that their system is not going to respond the same way as maybe a healthy individual that is active. The area that I've seen it studied the most is actually in fibromyalgia. And theoretically, fibromyalgia is a central sensitization disorder. There's a theoretical underlying autoimmune or potential inflammatory component within the body. And it has been studied frequently that if you initiate an exercise program, even a well dosed one, you'll see a couple of weeks where people will report worsening symptoms. And the term that is used commonly is called exercise windup, if you've heard that before. So you can almost predict straight away with those individuals that have maybe an underlying inflammatory disorder that, hey, you're going to get worse before you get better. We're still going to follow this dosage pattern. It's the right dosage pattern. We know that with chronic exercise, which is more structured, long-term exercise, that we start to see a change in the patterning, not only with cytokines, but with other tissue and mechanisms within the body. We'll see a positive, moving in a positive direction, but early we're likely to see a person worsening. And as a physical therapist, that's often why we lose our patients. So that's where that education piece, I think, really fits in when you apply an exercise program and kind of telling them what to expect with it.
Do you have any recommendations for a script as to how to have that communication with the patient?
First of all, sometimes it takes more than just that one visit. And I think there are a lot of principles from pain neuroscience that we can apply to this particular case as well. I think respecting the patient, letting them know that what they're experiencing is real, and being able to anchor it to something that has a true biological and psychological origin. And just telling somebody that, and I don't think physios do this, but there was a lot of, the pain is in your brain type stuff for a while, but pain is a lot more complicated than that. And pain can actually affect people through multiple systems, and letting them know that, and then re-altering the system takes time. There is an expectation. We've done this through hundreds of studies, thousands of studies. We know what the pattern is going to look like. If they bear with us, if they partner with us, if we work with them to help reduce the pain that they're experiencing during the ramp up period, then most likely we're going to start seeing results with this as well. And because a lot of folks will have sleep disorders with this too, one easy way for them to determine if they're improving is to look at the regularity of their sleep, how their sleep cycles are changing. All of those tend to occur concurrently. So you can talk about that some and then get the patient on your side. Obviously, it doesn't always work, right? We don't always have successes, and some patients are looking for a quicker fix. But for the long term, there is evidence to support that aspect of it. I want to emphasize too that cytokines can fit within this characterization, this presentation of the patients. It's not the only biomarker that's involved in this, but it's certainly one that has been very well studied.
Right on. So it's interesting for you to relate it to fibromyalgia, which I want to circle back to. Understanding the pro-inflammatory process with fibromyalgia patients and how there might be that exercise windup, and now incorporating your manuscript, which seemed to have a limitation on manual therapy, or how would you incorporate manual therapy with that patient to possibly offset any exercise windup?
Yeah, that's a great question. I'll start by just mentioning that really found that manual therapy at best was inconclusive. Its effect on neuroimmune and inflammatory cytokines. There was some evidence that it did change it. There was some evidence that it didn't. Most of the evidence suggested it's completely unclear. That said, if indeed manual therapy has less of an effect on cytokines, then its clinical effects must be from some other form of treatment mechanism. And that treatment mechanism is probably more pain modulatory. So targeting some of the other systems would probably be recommended in that particular case to help offset the pain of the individual. Not suggesting that what I'm doing is affecting your inflammatory or neuroimmune system, because we really don't know that. But what we do know is it has a very strong pain modulatory effect, and using that to get them over the hump.
And the reason why I ask is I tend to stay away from the manual therapies with my fibromyalgia patients and normally work with the idea that if they do a low level aerobic activity like walking and just some consistent moving, such as walking, that helps to manage those increases in pain that they might experience initially.
It's a good opportunity to explain what this means. It's actually really complicated. It's nice to have a straightforward, here's what happens if you do this. Unfortunately, the science doesn't suggest that. There's something called crosstalk in the paper. And essentially, what happens is all of the cytokines interact with one another through crosstalk. And it's almost like a pinball game. It's just bouncing around into directions that are completely unpredictable. And then the cytokines will interact with other mechanisms, other biomarkers in other areas to create this complex composite of responses. In fact, it's funny because when we talked to some of the cytokines researchers that reviewed our grant, they very much said, whew, you picked a tough topic. It's hard to measure. It's hard to manage the error that you commonly see in measurements of cytokines. I mean, you have to be consistent on the time of the day. You have to be consistent on how it's measured. You have to be consistent how you do a blood draw, how long the temperature of that blood draw, all of these things. It's highly complicated.
Well, and your paper made it elegantly readable and it made a lot of sense to me.
Well, I had some great co-authors. I mean, Damien Keeter, Bill Reed, first time working with Beth Winkelstein, and then Todd Cade, who is a metabolics researcher. These are folks that have, on the mechanism side, basic science side, that they have specialized in communicating to clinicians. They helped really kind of smooth the language. Thank you for that.
It was a nice read. So it seems that the magic happens when you review the identified variations in the findings of exercise and manual therapy. To put that all together, you're saying that exercise alone doesn't necessarily influence these cytokines. And we shouldn't say that as a treatment mechanism because it's going to have an influence on a lot of other of the systems. And you've touched on the importance of sleep, diet, health behaviors like smoking. I guess the nature of the question, Chad, is would you prioritize any of those?
So, what we know from the narrative overview is that exercise performed in the right dosage and the right regularity can actually mediate cytokines in the way that we want, that should be positive as a treatment mechanism. The challenge is if a person has a multiple other conditions or other areas that can actually confound the effects of that exercise. So that if we were a singular provider and all we did was exercise and we weren't holistic in the way that we managed that patient, so we didn't talk to them about sleep, we didn't ask them about their diet, if we didn't recognize that their behavioral habits can markedly influence and negate all the benefits that we see, that 45-minute drive home in traffic where they stress out about their relationship or their work or whatever can completely offset everything that you've done with them. If we don't package that into how that patient is managed, then we may not see the benefits from exercise. Exercise is going to have those inherent benefits, but if we aren't holistic in the way that we look at those other factors, those contributing factors, we're not going to be as successful.
That's well said. an elegant answer to a complex question that I laid out.
And Tony, patients are complex. For a long time, we went with this whole idea that there should be certain interventions that you should do. Everybody should get, everybody with low back pain should get one of 4 interventions. I'm not sure that holds up. Patients are a lot more complicated than that. There's inconsistencies as response, as I said before. And I think we should endeavor to do what's best for that single patient in front of us. And that may be different than the person you just saw.
I completely agree. I would imagine that if there were physical therapists pushing back on that, they would push back on it specifically because of the mandates of the healthcare system. Where you see a certain number of patients and you see them back to back to back, and it becomes very difficult to manage patients individually, which normally requires a little bit more time, a little bit more communication. And it seems to me the healthcare system doesn't do a particularly good job of that.
Indeed. In the VA study we just completed, the PCPs were able to spend an average of 8 minutes with patients who had low back pain. And typically those patients with low back pain had 3 other health-related conditions that they were trying to address as well.
I always take the time to understand my patient at an individual level, but that comes at a cost. I end up having to do more paperwork towards the end of the day. But I love dealing with the complex patient. It's where I thrive.
I mean, there's nothing worse to me in the world if I had a whole schedule of ACL patients. Yeah, that would be terrible. I like the complex patient too.
Yeah. Oh my gosh, you have no idea how many times I've said that. With the exception, I'd always say total knee replacements,
Yeah.
but because you can have some fun with ACLs. I do have one question about that because one of my passions is mindfulness and mindfulness meditation. Where would you put mindfulness on that scale with the complexities of our patients and individualistic approaches?
I think it depends on the patient. If you look at the moderator designs, it's certainly an approach that incorporates mindfulness, incorporates more cognitive training. Typically, those individuals with higher levels of disability, lower levels of self-efficacy are the ones that are most responsive to that. I don't believe that every individual we see with a form of musculoskeletal disorder needs formal training in areas such as mindfulness, but I do see it as a package, just like when manual therapy is used, I see it as a package deal. I don't see it as by itself. So there are variations of multimodal care that is applied, and it really depends, I think, on the pain and disability of the patient and looking at that signature from them.
Your manuscript also mentioned kind of the well-established balance between pro and anti-inflammatory responses to those peripheral tissue injuries. What recommendations or comments do you have about the evolving principles of peace and love, compared to the traditional rice or price that we used to employ with our patients?
Yeah, and I'll preface my thoughts here by saying most of these are preclinical studies, so that were incorporated in this paper. So most of these were basic science studies, animal studies. You may see different responses on injured tissue or tissue that's not manufactured injured tissue or not injured animal tissue. My understanding around peace is that, which is a little bit of a change, is avoiding the anti-inflammatory modalities and letting the normal inflammation take place because it can actually be beneficial. There weren't a lot of studies that went into that. Most of them, within the ones that we evaluated, talked about when the inflammatory system goes haywire, and that tends to have a time component on it. For those early stages or for immediate care, I think the peace principles actually work pretty well. And I think you mentioned love principles too for subsequent management. That's the optimism piece of that, I think, is huge. That's why we do so well, is that we create a contextual environment for people to feel like they can optimize their healing. We improve blood flow. We provide an exercise program, whether it's dosed correctly or not, that is also going to provide a contextual component and more of a neuro component, most likely. And then the load piece, I think, plays a valuable role. And you already mentioned earlier in the podcast how important that piece is. You think we underload? I completely agree.
Well, thank you for sharing those thoughts. It seems like you've touched on the limitations of your manuscript along the way. Is there a summary that you would like to offer on those and how we can move forward with clinical practice and additional research?
I think the takeaway is it's minestrone soup. The type of papers that we collected, there's 50 different ingredients, so they're not very consistent. Despite that, if you look at the exercise and how it affects the different cytokines is fairly consistent, regardless of design type or preclinical or clinical or whatever. So that part of it, I think, is pretty clear. The manual therapy part of it, there's just not enough information there. And the studies that actually were used often had very questionable treatment fidelity. And Tony, what I mean by that is that the dosage of the manual therapy, the type of manual therapy used, it was really questionable whether it would be clinically effective or not, or whether it would even have an effect at all clinically. It probably looks very different than what we would apply to our patients. So there are a lot of question marks around that, which, every paper only tells you a small story. And this tells a little story. If anything, it tells us, yeah, exercise seems to have a pretty notable role in the influence of cytokines. And we need better research on the manual therapy side if indeed we believe that manual therapy influences cytokines.
So I noticed that you used a narrative overview. How is that different from a systematic review or scoping review?
Yeah, so a scoping review is typically performed when there's not a lot of literature and you're really looking at the state of the evidence. It's kind of you're looking at the gaps in the evidence, what we know and what we don't know, and that usually don't do a risk of bias score or look at the quality of the research behind it. Most of us are familiar with systematic reviews, and it's very regulated. You're very careful about how you look at the information. You extract the data the same way, and then you evaluate the work for risk of bias or quality. And then the idea behind it is that it's supposed to give you kind of a critical level of where the evidence is. In cases where there's great variability in the research question, that there are different study designs, and that you're looking for almost a summary by the authors to go into detail and to give their viewpoint on, hey, this is what we found and this is probably what it means. That's really where a narrative overview will shine. If you wanted to do a systematic review on the state of spinal surgery, you would get into a discussion about, is it ethical to do spinal surgery on people who don't have leg pain? Is it spinal surgery? Does it really matter, the different devices that are used and whether or not there's a rat race to do all these different devices, but really they all have the same effect? Those sort of things fit into a narrative overview. There's greater flexibility in actually talking about the results that are found. We opted to go that direction because we knew there was a lot of literature, and holy cow, there was. I mean, heaps of studies, tons of work, that, especially on the exercise side, and it needed somebody to go in and interpret that in a way that a clinician can say, okay, I can see what the takeaway is.
It did offer a good takeaway. And overall, I think you've given us some actionable ideas as how we could employ this with our patients. So thank you very much for the conversation. Do you think there's going to be a follow-up review to this or study to this?
Tony, I don't think so. Yeah, this was pretty brutal. And we did submit an R01. We were not funded. And then the summary statement from the individuals really highlighted how difficult it is to do appropriate cytokine research. And because our design was translational, which incorporated a clinical component too, really muddied the waters even further. So I doubt I'll continue to go in that direction. If you get a chance, take a look at some of Damian Keter's work. He's doing some really cool stuff. Keter. He just led an international Delphi on gaps in mechanisms research in manual therapy. It's really interesting. It really highlights the areas that need to be studied, areas that we don't know much about. And he's a rising star. I think he just was awarded the Emerging Researcher Award at AOMPT.
Well, thank you very much for your time. I really appreciate it. This has been an enlightening conversation, providing empirical and anecdotal clinical pearls.
My pleasure, Tony. I appreciate it. Thanks for the invite.
This has been a production of the American Academy of Orthopedic Manual Physical Therapists. You can learn more about the Academy by visiting our website at aaompt.org. You can also find us on Facebook, Twitter, and Instagram by searching for our acronym AAOMPT. The views and opinions expressed on the AOMPT podcast are those of the interviewers and interviewees and do not represent the official position of AOMPT. The information presented should not be used as personal healthcare or clinical practice advice. If you need to find an expert orthopedic physical therapist near you, then check out the Find a Fellow feature under the Public Resources tab at www.aaompt.org, which you can find in the show notes.